Hi, good morning, everybody. Before we get started, I would like to acknowledge that I work, live, and play on the ancestral lands of the Musqueam, Squamish, and Tsleil-Waututh nations, and today I'm coming from you from those lands. If you'd like to acknowledge the land that you are in BC, feel free to put that into the chat so that it can be acknowledged. And Pat, I will pass it over to you.
Sorry.
That's
Yeah.
okay.
As you can see, my name is Pat Mauch. I was a care partner for many years as my husband managed very well his Parkinson's for 27 years. Actually, we managed it as a team. We both were very much part of that, as care partners know. We worked together to do as much as we could for as long as we could. Our philosophy was postpone nothing, and that could be something really big, like a big trip, or it could be something like going down to Kitt's Beach and walking and looking at all the different ships out there sitting there waiting to come into the port of Vancouver. So we did this until we couldn't do it anymore, and then we needed to get some extra support, but we'll talk about that much later. So now to Sky.
Yes, good morning. So my name is Sky. First and foremost, I'm a mother to 3 children, wife, sister, daughter, and daughter-in-law to aging parents on both sides. In my professional life, I am a social worker, registered social worker. I have experience working in the public sphere under one of the health authorities as a long-term care case manager, so helping folks like yourselves manage a loved one who's ill at home and talk about choices about moving to long-term care, having home care in. I was also an investigator for adult abuse and neglect. So I have lots of experience in that sphere, and that's well, I will actually be drawing on a lot of my experience from that position. And also I have a private practice doing counseling for caregivers and care partners who have a loved one at home or in the community and are trying to balance the emotions, the behaviors, and the practicalities of all of the things that come along with that. So this is all the knowledge and experience that I bring to you today. So before we get started, I wanted to go over the title of our presentation today. So balancing duty of care with dignity of risk. So what does that mean? First, going to describe what dignity of risk is. And if you see me looking down, I'm in this little box here. I've just got some notes that I want to make sure that I get the definition right. So I'll go over dignity of risk and then duty to care, and then look at how we balance the two. And then we will proceed with our presentation. So dignity of risk, what does that exactly mean? So if we look at kind of the developmental stages and we look at children who are learning to make mistakes by learning from trial and error, we get an understanding of dignity of risk. So for instance, parents allowing their children to go on the monkey bars a little bit higher and higher each time, or a teenager learning to drive a car or take the bus alone. These are tasks that build self-confidence. They're risky, but as you complete them, they build self-confidence. So this is the dignity of risk, being allowed to take risk, building self-confidence, and in essence, building your identity as we age. And this allows us to become our full potential. However, when a loved one is compromised by illness or ability, physical or mental illness, this is when the duty of care comes into play, because somebody who's physically or mentally ill may lack judgment to weigh the risks of those activities. So this is when the caregiver or care partner has a duty to care. So what does that mean? Duty to care refers to caregivers' responsibility to provide the person with a safe environment in which to live. So when working with people with different abilities, caregivers or care partners must take extra precautions to accommodate the mental and physical challenges of those under care. So you have the duty to care for somebody, even though there's a bit of risk. So it's really this kind of historically, which has been a dichotomy, right? These two are kind of fighting each other. And hopefully what Pat and I hope to do today is show you ways that they can be balanced versus at odds with each other. So this really means having systems in place to place limits on those risks, but not at the detriment to the person's dignity and independence. So it's just kind of reframing it a little bit, mitigating risk, and we will talk about that as we progress. So balancing the two is not just about risk to the person with Parkinson's or the person who is ill. It's also about risk to the care partner, right? In terms of injury, mental health, that kind of thing. And Pat has an example of this.
Oh, I'm going to talk about it right now. Okay. So this is about sleep for, this is the important thing. Care partners need to sleep. A lot of people with Parkinson's get up a lot during the night. If the care partner is getting up every time, then that makes a really big difference. I think it's really important to be able to do that. So you have to plan ahead in many, many levels. You have to live in the present time. You have to do all sorts of things, enjoying your life as much as you can, knowing about the future, but not dwelling on it. So it's really important about learning about the condition, going to appointments with your partner, doing the various activities with your partner, learning what resources are available, like Parkinson's Society, like things we're going to be talking about in the future, and for the person with Parkinson's as well, the person who's the care partner. You have to find out about many different household supports there are. It can be as simple as having one of those chairs in the shower for safety. It can be something like having the lifter on the bed, so for helping people getting in and out of bed so they don't fall. There's sort of a little handle that you can get installed. Could be having a commode at the bedside to make all those walks less during the night. Your health authority can have somebody come out, assess your environment, and recommend what things are good or not good or what you should do, and go from there. So it is remembering that you are a team, and as a care partner, you are a team. So you both need those different supports. Yes.
Thank you. Thanks, Pat. So as you can see, we have prepared a bit of a dialogue, Pat and I, one being the professional and one being a past care partner, of questions that we found often come up and issues that come up along with Alana. So we prepared a dialogue of kind of just asking each other questions and allowing the other person to answer. And hopefully we'll answer some of the questions that you have out there today. If we don't, we'll have a Q&A, question and answer, at the end. So certainly type in your questions as we go through, or you can save them until the end. We might actually answer your questions before we get to the end, and then we will try and answer them as best as we can at the end of our presentation. There are no slides for this presentation. It's very informal and friendly. We want to make everybody feel warm and welcome here with us. So if you have a pen and a paper, certainly take notes as you go along, and this will be recorded, so you'll be able to refer back to it. So Pat, I think you did just cover how do you plan ahead for safety for a partner. So thank you for that. Moving into self-care, how do you engage in self-care for you and your partner at the same time?
Well, first of all, self-care is not as easy as it sounds. It is just not as easy as it sounds. So I think what's really important is to say your own self-care is like your life jacket. If you were going swimming, you'd put on a life jacket. If you're looking after your partner, you want to be having your own life jacket on. So it really is important. You need to do many things. You need to live each day the way you've planned. You need to maintain your friendships, your different activities. You can include your partner in as many as they are comfortable going to and participating. When safety becomes an issue, then you need to be able to, if you cannot leave your partner alone at home for a period of time, you need to be able to contact your local health services to have somebody to come in. Or sometimes that can just be a friend or a family member. For my husband, people would say, who's that great lady that goes for a walk with George when you're out at the airport volunteering? All those different things. So those are really important things too to have. Sometimes be important that they understand the condition. That is another very important thing. They need to understand the condition. They need to understand some of the safety concerns. And those are all the different things. Going back to that sleep thing, that was one of the things that Sky and I had talked about. My family did not want me to keep going on without sleep. So they wanted, that's when we eventually had to bring in some other help supports as well, because you cannot care for somebody if you cannot care for yourself. So that's really important. It's important to work with family members, keep up your own mental health. Yeah.
Right. So really engaging your community around you. And if you don't have that community around you, Pat is right. There's often home care respite that is available through your local health authority. Sometimes adult day programs. We didn't touch into that as well.
Oh yeah, adult
yeah.
day programs are great. There's a lot of them in Vancouver, and I'm assuming there are in many other parts of the province.
Yeah. So tapping into your local health authority.
Yeah.
Calling their central intake number, their main line for those resources. So Pat, along with self-care, another theme that often comes up is guilt. I deal with this a lot in my private practice. There's so much guilt that goes along with care partnering. So how do you manage any guilt or that kind of sense of responsibility if the person is still progressing while you're doing all that you can to help your partner?
Well, I think first of all, you have to know that you are doing all that you can. We all have different skills with that, and they're not all the same. So whatever you are doing your best. And you have to keep reminding yourself that. If you're feeling that you are having that sense of guilt, as Sky mentioned, or you're blaming yourself for something happened, then it's time for you to talk to a counselor for you, not just about your partner, but for you. So that's an important thing, to be able to talk to people. I think that one of the things is you just need to know you're doing the best that you as an individual can do. And one of the special poems I was telling Sky about that I always had up on the wall here, it's God grant me the courage to accept the things I cannot change, the strength to change the things I can, and the wisdom to know the difference. And that's the hardest part, is to say, I can't really do all of this. So that is a really important thing to understand. Sometimes it's best to just talk with somebody else, again, a counselor, a friend, the support groups. Support groups. There are support groups for care partners. There's support groups for both together. So there's all sorts of different ways to talk to others who are in the same situation. And I think the support groups are a very, very important resource through the Parkinson's Society BC. So, yes.
And going along with guilt, I would say if you are feeling that, you are not alone. Every single care partner I work with over the last 15 years has some sense of guilt, and it's usually based in that they're not doing enough or they should be doing more, among many other things. So you are not alone, and definitely I think those support groups are wonderful just to kind of normalize and validate all of those things that you're feeling. So Pat, we're just going to kind of switch gears here, and Pat's going to ask me a few questions. And once again, take notes if there's anything that you're not quite understanding, and hopefully I'll be able to clarify it for you. So Pat, I'll hand it over to you.
Yeah. So sometimes your partner, Sky, sometimes your partner can be resistant to some of these activities, which can increase their risk. How do you have suggestions for how care partners or family members can handle this resistance to certain activities?
Right. And this is it, right? This is the dignity of risk and balancing that duty of care. So rather than being at odds with each other, how can we balance the two? So this is kind of like a four-part answer, but my answers are brief. So I mean, one example that Pat gave earlier is having mobility aids around the house to reduce risk. But what if your loved one doesn't want to use one of those aids or is resistant to having them in the bedroom for dignity and pride reasons, using a walker, using a wheelchair, those kinds of things? and then it poses risk to care partner and also to person with Parkinson's. So, my first piece of advice is to look at the activity that is risky and ask, is the chance high or low that they're going to injure themselves, right? For instance, if they are not using like a bed assist rail or a railing to get out of bed and they really do need one, that could be risky, right? If they don't want that on the bed, then we don't put it there. But is there a high risk that they're going to fall? Have they fallen in the past? Is there a walker close by that they can grab onto? Is there a higher night table that they can grab onto? So putting other measures in place and looking at the potential for risk. Is this really risky? And measuring that high or low. What I often say to patients, or not patients, that's my other position. What I often say to clients is, are they going to end up in hospital? If you're thinking that you're going to be having to call 911, I would say that's a higher risk, right? If they're going to miss one pill in the morning because they need to go somewhere or do something, or they don't want to take that one pill in the morning, that's a bit of a lower risk. We're not going to be needing to call 911. So those are just two very broad examples, but always looking at the level of risk and being realistic about that. That also goes, I think I just mentioned, but looking at the risk that it poses to the caregiver. So looking at your level of risk, right? If somebody falls and you have to bend over and get them up, are you going to put your back out and then not be able to care for them in the future? That's a pretty high level of risk. Are you going to have to call the fire department to lift somebody up if they fall? That's a higher level of risk. This one comes up a lot for me, and this is called cognition. So what if somebody is not able to figure out the level of risk because cognition is slipping or kind of going down that trajectory of not really being able to realize those different types of risk? So what I would say is, does your loved one appreciate the consequences of taking that risk? So if you ask them, do you know what will happen if you don't do X, Y, and Z? And if they really don't have a clue, then your risk is going up higher, because that means if they do that activity and put themselves at risk, they're not going to know how to get themselves out of it. They're not going to know how to solve that problem. If they do understand the consequences and they say, yep, I'm going to fall, or yep, I'm going to miss my medication, or I'm not going to go to adult day program, I just want to stay at home, and they understand that and they have good reason for it, that's where the dignity of risk comes in, right? That's where the ability to honor their self-determination comes into play. And then we look at other ways to mitigate that risk. So putting in other measures, or there's lots of different ideas I would have, but you would just be mitigating the risk at that time and honoring their dignity and their self-determination. I think that about covers it, Pat, for that one.
Okay. Now, one of the other issues that come up is, how do you know when you're helping too much? When you're helping too much at the cost of that person's independence and sense of dignity.
Right. So this often happens as well. I get lots of questions saying, should I be doing this much for this person? Am I empowering them? What I would say to that is I'm kind of just going to take this on like a trajectory. So if you have an early diagnosis, I would say discussing that trajectory with your loved one early, discussing the symptoms and abilities that might change as your illness progresses. So having a conversations about independence and dignity. So for instance, if I was to have that discussion with somebody, my partner, my in-laws, look, this might happen. You may or may not become incontinent at some point. Will it be okay for me to change your incontinence brief? Because that is a really, it can affect somebody's dignity to have their loved one doing the very private personal care. Having that conversation, is it okay if I do it, or would you like me to hire and have home care come in from the health authority? So actually having those conversations early, if you can, and writing them down, writing the answers to those questions down and having them in a little file folder or on your phone, in an email, because when those risky points hit, our emotions are generally quite high and we forget what we've discussed already. So writing them down, so it becomes kind of like a blueprint for how things might go. speaking of those transition points, so a transition point is when, for instance, you're going pretty fine in your illness, and then a fall or a flu or something happens and you're going to go down a little bit, and you maybe go to hospital and get a little bit better, but then your baseline becomes a little bit lower. So those are transition points in an illness, in a mental illness, in even in our lives. Those transition points are key. And I would say to have discussions at those transition points as well as in the beginning of an illness, because those transition points are when the dignity also often drops a little bit, and the care partner has to start doing more. So it becomes a little bit imbalanced. So if you remember at those transition points, having a discussion about that. Usually when you're in it, it's quite chaotic, but even a few weeks after, it's never too late to have a conversation about dignity and what that means to that person. I'll slow down for a minute just to let everybody absorb. I feel like I'm talking very quickly. And the last point I would say, if you feel like you are helping too much, trust your gut. Trust your gut. This is your body telling you that something is not right. We have our nervous systems that have been in our bodies since the beginning of the time, designed to tell us when something is not right. So have a discussion about it. If you feel like you are empowering your loved one, have a chat about it. If they're not able to grasp it, have a chat with somebody else in your community. Have a chat with home care nursing or whoever else is involved, with lots of the volunteers, support group leaders. Have a chat about what's going on, because I can guarantee you, if you're feeling that way, there is a solution out there. You're not the first one that's going through this whatsoever. So trusting that gut. And I think, as Pat mentioned earlier, another note here I have is, if you are in doubt and you feel like you're doing too much, you can ask an OT, an occupational therapist, or a physiotherapist to come in, who, they work in the local health authority. It's for free, can come in and assess your house to see if you are doing too much. Maybe we can put in some equipment or some modified eating utensils or modified utensils to help people put on their socks by themselves, or those kinds of things. There's so many things out there that we don't even know exist until we ask for help. So there's my answer to that. Pat, did you have anything to add? Did you have anything to add to that?
Oh, right. Well, now, when I was doing a presentation with some care staff in a care center, they have the same issues. They have the same questions. Am I doing too much? Should I do this? And one of the things that seemed, when we had a discussion that seemed to work for them, is to involve the person verbally in it. Oh, those sleeves look awfully hard to get into. Can I help you get into those sleeves? Or, yes, I'm walking down there too now. Can I just walk down with you? So these are things where you involve the person personally in the activity rather than just doing. And even for care staff, they felt that made a difference. They felt more comfortable. The person they were looking after, whether they had Parkinson's or anything else, whatever, made a difference. So that was one thing that they had shared. So, yeah.
Thank you. Thanks.
So now we have another question for you here, Sky, all ready to go here. How do you instill confidence in a partner with Parkinson's to help them see and carry out so that they avoid their sense of helplessness? How do you give them confidence?
Right. So this question is about giving confidence to the loved one with Parkinson's disease. How do we increase, if at all, or maintain their abilities and independence? Validate, right.
Yeah.
So, just a bit of psychoeducation here. So confidence comes from knowing that you can do a certain task. We all know that. And the key to confidence is you don't even need to do it well. You just need to know that you can do it. And the more you do it, we build confidence in that task. So, I mean, it's not rocket science. The same goes for our loved ones, and it's building confidence in those small steps. It's like building blocks, right? Like learning to ride a bike, you learn to brake, you learn to pedal, you learn to hold the handlebars, and then you learn to ride a bike. So for our loved ones, it's the same. So they might need help at certain stages, but like Pat said, giving them pieces of the tasks to do on their own, like putting their sleeves into a jacket, or putting on socks, or taking medications, or maybe just taking a morning med and somebody else administering afternoon and evening medications. Just those small little building blocks can help maintain or build confidence in a loved one. And for this question, I wanted to provide just like an anecdotal story from my own personal life in terms of building self-confidence in a loved one who suffers from chronic illness. And this loved one asked me to, she needed a scooter. So her mobility was quite, a lot of falls are happening, and wanted some independence to get around in the community. So wanted to get a scooter. And she knows that I have experience in healthcare and this kind of thing. So she asked me to just do it for her, just get a scooter for her. And I was kind of a little bit like that gut feeling that I was talking about, that gut feeling of like, I'm feeling a little bit uneasy about doing the entire thing for you. This loved one is cognitively sound, so can manage tasks, but mobility challenged. And so instead of just doing it for her, she has a phone, she has a smartphone. So I provided links to vendors in the Lower Mainland. And I said, you know what, here's 3 vendors that have come up on my Google search. So why don't you call them and get a sense of which one you like and make an appointment, and I will come with you to the appointment, right? So still walking alongside the person, but letting them do certain tasks.
Mhm.
So she did that, and it was great. I went to the appointment with her. We trialed the scooter, and then they need to do a follow-up appointment to bring out the purchase scooter and do like a test drive around. And I said, okay, I can come with you to that appointment. And she said, no, it's okay. I think I can take it from here, right? So she had her spouse beside her who, to be quite honest, wasn't much help at all. It was just a person standing there. But just knowing that she had made an appointment, she was able to choose a vendor on her own with somebody who she trusted, was really big in building her self-confidence. And actually, just to add to this, Pat, it's funny enough, yesterday she got stuck in the middle of a street in her scooter and it lost power because of the heat, because it was so hot. She was trying to go uphill. But because she had built up such a good relationship with the vendor, she called him and he came right out, moved the scooter, and without us going through those steps, she would have called me to help her, and it would have, and then it kind of cycles, right? So she had enough confidence to figure it out on her own. So that's just one small example, and I know this doesn't generalize to everybody out there, but it's just about building those pieces, right? So that people have a bit of a stronger foundation to stand on. And that's it for that question.
Yeah, the next part of this is often cognition starts to be affected. So once the cognition is more limited, how do you help that person become more independent? That was a very independent person, but what about with the cognition part? Yeah, that's a hard one.
It gets harder, right? It gets much harder as the cognition starts to decline. So the first thing I would say is figure out what you're talking about. What is the activity? What is the risk that you want to talk to your loved one about, that you feel might be a risky activity or that you want to build confidence around? And do they have limited cognition around that domain? So cognition can be sometimes domain specific, right? So what I mean by that is sometimes person or people can lack short-term memory, right? Where they don't remember what pills they're taking and they have to have somebody else administer pills, but they can still get themselves dressed. They can still, they know that long-term procedural memory of making a cup of coffee or warming up something in the microwave. They know that. So that's cooking, but the domain of short-term memory and medications is impacted. So what I'm saying here is to really look at the domain that you're talking about and see if their cognition is limited around that. I have an example for that. I often work with families whose loved one, who they feel like their loved one needs to move into long-term care because of, they can't take their medications or they can no longer cook for themselves. So we have a conversation with the person with Parkinson's or with, whatever chronic illness is going on, often a dementia and Alzheimer's.
Mhm.
And often the person is pretty intact about knowing where they want to live. That domain is, where do I want to live safely? And they can give very good reasons why they don't want to live there, right? So this is kind of going back to one of my earlier points of, do they understand the consequences of this risk? So yes, I can't take my medications. Yes, I burn my food on the stove, but I really don't want to move into long-term care because it can be isolating, or I don't want to be institutionalized, or when I wake up at 10, I don't want to have my meal at 7. So those are pretty good reasons, right? That we have a discussion about that. Oh, okay. Well, then how can we mitigate the other risks, the risk of the medications, the risk of the fires in the kitchen? And we have conversations about that. So that is keeping that person independent, right? Assessing the cognition, looking at what domain is impacted, and assessing the risk. So it's all of these things at play all the time. And that's why Pat and I are really encouraging you to don't do this alone. Like, bring everybody in, because there are so many moving parts to these conversations. And it's, when you're in it, sometimes assessing cognition that's not your thing to do. You don't have any expertise in that. That's why you would bring somebody like myself in, or your case manager or the health authority, because we can really, really, really help with those gray zones, I would say. In addition to those discussions, I would say, before I said, write stuff down, write everything down. You can have legal documents in place that says the care partner can make these decisions around where to live, around finances. And a couple of those, and examples of those documents is, power of attorney, which gives a care partner ability to manage finances in BC, representation agreement, which can cover personal care and healthcare decisions. There's advanced directives as well, which is similar to like do not, like a DNR, do not resuscitate, which would sit with your doctor. So there are all of these documents that can be done earlier on, at earlier onset, that you have in place so that when those transition points happen, you're honoring independence by saying, we've had this discussion, this is what you wanted, and here I'm going to help you to make these decisions around healthcare, where to live, etc. I'm going to ask Alana in a minute to pop that link to, there's a document called My Voice, which is put out by the province of British Columbia through, I believe, the Ministry of Health. Yeah. And then it's called My Voice, and it has a representation agreement in it. It has advanced directives and all like really good worksheets and questions to ask yourself about what your goals are, what your loved one's goals are. And the actual documents are in there. You can fill them out, get them witnessed. Representation agreements do not need to be notarized. So you can do that if you like, and either download it or request a print copy if you like. It's a very, very good document. And I think the last thing I would say is that when cognition is limited, go back to looking at risk and find places where you might be able to mitigate that. Once again, if it is too risky, if you feel like somebody is going to end up in hospital or they're going to have a severe illness, a severe fall, always err on the side of safety. So when cognition's in question, I would say to err on the side of safety, or put a lot of mitigating risk or mitigating factors in to reduce the level of risk and bring up the safety. And by that, I mean, like, let's see, in terms of medications, if somebody really, really, really wants to take their own medications, and I get that, I have many clients who this is their regime, this is their pattern. They don't want you administering medications. Perhaps ask the pharmacist to blister pack the medications so they're in a nice package. AM, PM, lunch medications are all in little bubbles. Loved one can still pop them out and take them, but they're not mucking around with vials and spilling medications. And then you can also see if they've taken their medications. So loved one is still having quite a bit of independence, but there's still some safety there. So that would be one of those mitigators to safety around, missing medications, for instance. I think that is all I had to say about cognition, but I'm, very happy and willing to take any questions around that. that might come up for you. Pat, did you have anything to add to the cognition part?
One of the things, and it's not just the cognition, it's about the resistance generally, when you mention about resistance going into places, as well as the partner, the care partner. Family also can make, just like you were talking about with your aunt. So, you might have been able to get her to do things that maybe her immediate person right there might not. So I think getting family involved as well, children, nieces, nephews, all those things can make a difference for the person by saying, oh, we recommend, oh, we'd love to do that. Oh, that would be good. So I think that's another, sort of a little bit sort of manipulation 101. But I mean, they also have a big impact on the person who might have advanced Parkinson's cognition issues. So yeah, just thought I'd throw that one out.
Yeah, I would. Yeah, you're correct, because in that example I gave with the scooter, had her sons tried to help her, it would have been a battle, that's for sure. So that's why I was pulled in to provide that a little bit of an objective point of view. So yeah, right on. So I mean, that is a little bit of just kind of dipping our feet in the water of dignity of risk and duty to care. And Pat and I hope that we've covered some of the broad topics that are out there. What I would invite you to do now is just, give yourself a couple minutes to have a think about what we've presented, and pop any of your questions into the chat if you know how to do that. And Alana will moderate and bring some of those questions back to us.